Have you ever looked at an ABG with a pH of 7.56 and a CO2 of 25 millimeters of mercury, but wondered whether it's simply hyperventilation or whether there's another metabolic disorder hiding underneath? In the next 5 minutes, I'll discuss respiratory alkalosis, assess compensation correctly, recognize mixed acid-base disorders, and avoid the common mistakes clinicians make. Hello everyone. I'm Dr. Sunil. Welcome to the channel where we simplify acid-base disorders for critical care physicians, emergency physicians, anesthesiologists, intensivists, and internal medicine doctors. Today's topic is one of the most frequently encountered acid-base disorders in critically ill patients. Respiratory alkalosis is a primary decrease in CO2 due to alveolar hyperventilation, resulting in an increase in blood pH. The primary disturbance is decrease in CO2 and increase in pH. The kidneys respond by excreting bicarbonate, but this compensation takes time. Remember this simple equation. Hyperventilation causes CO2 washout, which in turn leads to less carbonic acid, consequently higher pH. Causes can be divided in 3 categories. Number 1. Increased respiratory drive. The common underlying reason of increased respiratory drive includes anxiety or panic attacks, pain, fever, pregnancy, liver failure, salicylate poisoning, early phase, and sepsis. Number 2. Hypoxemia. Main underlying reasons are pulmonary embolism, pneumonia, high altitude, acute asthma, and early ARDS. Number 3. Mechanical causes like excessive mechanical ventilation and excessive spontaneous breathing during ventilator support. Suppose the ABG shows pH 7.55, CO2 25 millimeters of mercury, bicarbonate 22 millimole per liter. Step 1. The pH is elevated, so alkalemia is present. Step 2. CO2 is low. Therefore, the primary disorder is respiratory alkalosis. Now evaluate compensation. Compensation rules. Acute respiratory alkalosis. For every 10 mmHg fall in CO2 below 40, bicarbonate decreases by approximately 2 millimole per liter. In chronic respiratory alkalosis means, after 48 to 72 hours, for every 10 millimeters of mercury decrease in CO2, bicarbonate decreases by approximately 4 to 5 millimole per liter. Example: CO2 20 millimeters of mercury. Decrease from baseline value of 40 is 20 mmHg. Expected bicarbonate. If acute, 24 minus 4 is equal to 20 millimole per liter. Chronic, 24 minus 8 to 10 equals 14 to 16 millimole per liter. If bicarbonate differs significantly from expected value, suspect a mixed acid-base disorder. Case 1. Pulmonary embolism. Arterial blood gas. pH 7.50. Partial pressure of carbon dioxide 28, bicarbonate 22. O2 58 millimeters of mercury. This is classic acute respiratory alkalosis due to hypoxemia stimulating hyperventilation. Case 2. Mechanically ventilated patient. Arterial blood gas. pH 7.58. CO2 22 millimeters of mercury, bicarbonate 20 millimole. Ventilator rate 28 per minute. The diagnosis? Acute respiratory alkalosis from excessive minute ventilation. The treatment is not bicarbonate. Simply reduce minute ventilation appropriately. Case 3. Septic shock. Arterial blood gas. pH 7.42. CO2 22 millimeters of mercury. Bicarbonate 14. What do you think this is? Chronic respiratory alkalosis or acute respiratory alkalosis combined with metabolic acidosis? How to differentiate between these two arterial blood gas findings? Always correlate clinically. As sepsis is acute, rapidly evolving process, the possibility of chronic respiratory alkalosis is less likely. The compensation in chronic respiratory alkalosis is more precise, so any deviation which is more than chronic respiratory alkalosis signifies metabolic acidosis. Means the fall in bicarbonate will be more than what is expected in chronic respiratory alkalosis. Additionally, any value of bicarbonate below 12 signifies combined disorder, as this value is less likely in respiratory alkalosis alone. Calculate anion gap to confirm. In this patient of sepsis, although the pH appears normal, this patient actually has respiratory alkalosis with metabolic acidosis. A normal pH never excludes a mixed disorder. Respiratory alkalosis affects multiple organ systems. Neurological symptoms including lightheadedness, dizziness, perioral numbness, paresthesia, carpopedal spasm, and seizures in severe cases. Cardiovascular sign and symptoms including tachyarrhythmias and reduced coronary blood flow. Respiratory alkalosis commonly causes decreased ionized calcium, intracellular potassium shift causing hypokalemia, and mild hypophosphatemia. Patients may become symptomatic despite a normal total serum calcium because ionized calcium decreases. Treatment focuses on the underlying cause. Ask yourself, why is the patient hyperventilating? Examples: treat hypoxemia, manage pulmonary embolism, control pain, treat fever, correct ventilator settings, manage anxiety, only after excluding organic causes, treat sepsis promptly. Do not attempt to normalize CO2 rapidly without understanding why hyperventilation is occurring. Remember, hyperventilation may actually be a life-saving physiological response. Let's summarize. Respiratory alkalosis results from primary reduction in CO2 due to hyperventilation. Always determine whether the process is acute or chronic before interpreting bicarbonate. Use expected compensation formulas to identify mixed acid-base disorders. Respiratory alkalosis frequently accompanies pulmonary embolism, sepsis, liver disease, pregnancy, salicylate toxicity, and mechanical overventilation. Management is directed at the underlying cause, not the ABG number. If you found this video useful, please like, subscribe, and share it with your colleagues. Thank you for watching, and I'll see you in the next video.